Women's health is on the agenda, and that's amazing. A lot of talking about the problems, but we need to get on and start building the solutions.
My today's guest is Sarah Stock, professor and consultant in maternal and fetal health. Sarah now is a program director at Wellcome Leap, leading the 50 million In Utero program, an ambitious effort to cut stillbirth rates in half by building scalable ways to measure and predict fetal development in real time.
2 million children die from stillbirth every year. That's more deaths than deaths from tuberculosis, malaria, and HIV combined. It's the fifth largest cause of death. If we counted them, it would be the fifth largest cause of global mortality. And in that low-income setting, it's the number one cause of mortality. I think there's a huge perception about how difficult pregnancy is, and it's a misperception.
Hi, welcome, Sarah. How are you today?
I'm good, thank you, Navneet. How are you?
Very well, thank you. Please tell me a little more about your background.
Absolutely. So I'm based in Edinburgh in the UK, in Scotland. That's my home. And I'm an obstetrician by training. So obstetrics and gynecology doctor, and then I did maternal fetal medicine, so sort of the high-risk pregnancy care specialist training on top of that. But throughout my career, I've done research as well. And that research has focused on the biggest causes of baby deaths, which is preterm birth and stillbirth. And so I started in laboratory, doing sort of wet lab science work. I moved through some preclinical models in terms of looking at medicine's effects and developing new treatments, and then into clinical trials and data-driven approaches, all focused around really better ways of saving babies' lives from these conditions that affect pregnant women. But that's one part of my career, and the more recent part of my career is stepping away from academia and coming to work for Wellcome Leap. And there I developed and direct the In Utero program, which is a $50 million global program aimed at reducing stillbirth.
So what led you to focus on stillbirth and maternal fetal medicine, and why?
I mean, a long time ago as a medical student, I really was inspired by some of the doctors during my training to do obstetrics. It's a fun specialty, actually. It's exciting, it's fast-paced, you work as a team. But very quickly, it changed into becoming more to do with the women and how you could see a real tangible difference in working in obstetrics and gynecology from conditions that affected their lives or the lives of their children. And then after that, it wasn't too long after that, that it actually changed again and became more about what we couldn't do, and recognizing that there were these huge gaps in our knowledge and our ability to do things, particularly in pregnancy and particularly around stillbirth and preterm birth. We seem to have this sort of, acceptance that it's just the way it was. And without a real understanding of how we could do better to prevent. So I got trained in bereavement care, but I didn't get trained in research in what was causing stillbirth or how we could prevent it. And I think that became a bit of a theme then throughout my career of going into research and really thinking about these conditions, these what have been thought of as sort of mysteries when I in some ways of why women go into labour when they do, why preterm labour happens, how babies grow and develop, and why some babies die in the womb. And thinking, first of all, from the fundamental understanding, data that's needed to fill those gaps, and then trying to develop new solutions.
Why do you think stillbirth remains so under-addressed despite affecting more than 2 million families each year? Is that data true? Or
that data's true. The numbers are crazy. So that's one baby dying from stillbirth every 16 seconds. And let me put that in context. So If we think about the World Health Organization definition of stillbirth, that's death of a baby in the womb after 28 weeks gestation. So that's the late stages in pregnancy when survival rates are very good. And that's 2 million children die from stillbirth every year. That's more deaths than deaths from tuberculosis, malaria, and HIV combined. It's the fifth largest cause of death. If we counted them, it would be the fifth largest cause of global mortality. And in that low-income setting, it's the number one cause of mortality. So these numbers are huge. So that makes it even more startling why we're not doing anything about it. And I think there's a few reasons. Stillbirths have been called by the World Health Organization the neglected tragedy. They're neglected because they're not counted often. Sometimes that's literally not counted. These child deaths aren't marked, but they're also not included in statistics. They're often underreported or not included in statistics on mortality. They don't appear in global mortality figures, for example. That means if we're not counting them, they don't appear in policy. They're not in things like the Sustainable Development Goals. And there's been chronic underinvestment in research. And that leads us to have a toolkit for antenatal care, which is really last century. The mainstay of antenatal care, of how we monitor through a pregnancy, still is a blood pressure cuff, a tape measure to measure the growing bump, and a urine dipstick. And so these things combined mean that stillbirths are kind of not in public consciousness, are ignored. When they do happen, there's stigma around them. People still find it difficult to talk about these child deaths. And there's also really important misconceptions. And one really key misconception is that these deaths are not preventable. If we think about those deaths after 28 weeks gestation, only 7% are to babies who have a birth abnormality, a structural abnormality, a chromosomal abnormality that could be considered life-limiting. 93% are to normally formed babies. And that means if we had better ways of predicting what was happening in the womb, detecting complications as they emerge, and being able to recognize and reduce that risk or deliver that baby in a timely way, these deaths would be potentially preventable. And I think that just isn't recognized. There's still this conception it's just nature's way, and that is just not true. And so I think these things combine to mean that they have not been high on the agenda. I would say that is starting to change, and I hope that continues to change. But it's been difficult to talk about stillbirth, but we need to talk about these child deaths to enable us to get to the solutions to reduce them.
You are part of your program director at Wellcome Leap. They are doing a lot of basically serving so many underrepresented sectors and really pushing the industry and forward. And I would love to know, how did you get involved with Wellcome Leap, and what is the vision behind the Utero program?
Yeah, absolutely. Wellcome Leap's an amazing organization. So it's a global ARPA for health. So that's an advanced research project agency. So it's run by the first female director of DARPA, the Defense Advanced Research Project Agency, which came out of the United States. So, if you don't know DARPA, or the listeners don't know DARPA, the internet came from DARPA, RNA vaccines came from DARPA. It's a proven model of innovation. And Wellcome Leap was started to see whether we could apply that model of innovation to health, with the aim of bringing health breakthroughs in years, not decades. Now, I didn't know any of this when I met Wellcome Leap, and actually, there's an official story of how I got involved, and the unofficial story is I think I was the token woman at a meeting and brought in at the last minute because they realised that they didn't have any women attending. But it was a meeting where at that time the chief operating officer of Wellcome Leap was actually in Edinburgh and was there. I was brought along, but because I was the only woman and brought in last minute, I was in a bit of a bad mood. So I didn't do what I think I was meant to do, is talk about all the solutions. I actually had a bit of a rant about the problems that we have in women's health generally, and particularly in pregnancy research, raising some of these problems about how we don't really understand some of the fundamentals and how our tools aren't fit for purpose for 2022 then, in terms of managing pregnancy. And he listened and came back and said, well, wondered if there was something we could do in this area. So then that resulted in me stepping away from my job, coming to work to Wellcome Leap to develop the In Utero program. And we focused on stillbirth because it's a big problem, but it's also the tip of the iceberg. If we don't have the technologies that you can detect the most sick babies, how are we ever going to get the technologies that allow us to improve child health? Of course, child health and adult health doesn't start at birth. What happens in pregnancy is absolutely fundamental for lifelong health. And we talk about improving that, but if we don't have the tools that allow us to detect even the sickest babies, how are we going to get the tools that can improve health? So we focused on stillbirth. We had an ambitious goal, which is to be able to develop new technologies that can predict gestational development, so see what's happening in the womb, with sufficient accuracy that we could reduce deaths by 50%. And then there's another part of that goal which is really important. It's to do that without increasing provider-initiated birth. When I say provider-initiated birth, I mean caesarean section, I mean induction of labour. And I'm sure you'll be aware, it's common knowledge that rates of caesarean births, rates of induction of labour have really gone up and up. And it's understandable, because we do that to prevent stillbirth. We do that to be cautious to make sure the baby's safe. But of course, caesarean birth and induction of labour carries its own burden to women, to children, to health services. And we do it because we don't have good ways of seeing which babies actually do need to be born and which can safely wait in the womb and for labour to start itself. So recognising that there was a gap there and we needed different technologies to be bringing together signals from mother, baby and the placenta to understand better what's going on in the womb and be able to reduce stillbirth by half, the fundamental goal.
How is the program structurally different from traditional research or funding models?
I'm going to tell you a bit about the model, and then I'm going to tell you how it feels, because I could read the words and I was like, okay, that sounds okay. It doesn't sound that different. And then actually having gone through it, it's really quite different from what I was used to in a traditional academic setting. So the Wellcome Leap sort of ARPA-type model is really, as I say, focused on stacking the odds for success so that we can get breakthroughs quicker, doing things in parallel so we can get health breakthroughs in years and not decades. And I think there's sort of three key things about that model. The first of all is that the research is use-inspired research. It focuses around a problem that can be solved. And in our case, that's stillbirth. So it's not sort of a sort of hypothetical, it's not general sort of iterative research, it's a focused problem and focusing on that. And it requires a really ambitious goal, and that goal's got to be measurable and time limited. So in Utero's case, 50% reduction in stillbirth. And the second thing that's really important is the networks. So it's a global we're a global ARPA. We bring in diverse networks, academia, multidisciplinary, industry, sometimes other not-for-profits. So bringing in people from around the globe with different expertise, all working in concert towards that focused goal. And as a program director, one of your roles is to bring those people in and to be coordinating and sort of conducting the research efforts towards the common goal. And then the third thing is a word that's easy to say, but actually hard to do, and that's the agility. And we have structures in place that allow us to move really quickly and iterate, so that we can gain momentum. This isn't about speed for speed's sake. We need to be robust, but it's about being able to generate momentum and adapt to results coming in. We're not giving money, waiting for a long period of time, getting the results and seeing what happens. It's constant responsive to what's going on in the programme, the developments that are going on, iterating so that we can get to where we need. So that's the kind of theory. What it felt like in Utero programme was, I started in May 2022. Within 100 days, we had assembled, we started with 13 teams around the world. We went up to 18. That was more than 240 researchers across 6 continents. And when I say assembled them, they were contracted, money in accounts and starting work in 100 days. Now, a traditional grant application process that I was used to would take about a year from the time of the call to application, and then another 6 months to actually think about getting money in accounts. So, that's rapid. They were starting work, with money in accounts on day one. By year one, we had signals that we could predict conditions, placental conditions like fetal growth restriction, which is a cause of stillbirth in about 40% of cases, or associated with stillbirth in about 40% of cases. So we had signals that we had new biomarkers with up to 80% accuracy for fetal growth restriction. By year two, we had medical device regulated studies for new fetal activity trackers with an aim of seeing how babies were moving objectively and whether changes in movements could be detected, because we know that unfortunately around half of women who experience a stillbirth will look back and say that they had a decrease in fetal movements in the week before their baby died. And in year three, we had new technologies that were predicting oxygenation in the baby using clinical measures and ultrasound, so making that accessible even in potentially low resource settings. And then, so by the end of programme, what we had is these bones of a new maternity care system, really, addressing key areas which we think had potential to reduce stillbirth by half. We had other work doing key infrastructure pieces, thinking about how we can digitally enable these technologies, how we can collect signals in between antenatal care visits and bring them together in structured risk prediction platforms. And when we put these data together and modelled out the potential effect, what was quite amazing was when we did the simulations, we found that we were actually getting a potential 47% reduction in stillbirth, which is way more than I had set the goal, but in my heart I thought, I think that's so ambitious, I'm so anxious that we'll get there. And actually when we modelled these out, we got to 47% reduction in stillbirth and an 18% provider-initiated birth rate. So really showing that, within what you can do in 3 years with people working at pace is get the technologies with the potential to achieve our goal and transform maternity care.
And I love that you said it's very global and diverse as well. And I know you also work with a lot of startups, right? And tell me more about what kind of technologies or startups are the most needed to help measure maternal and fetal health at scale.
Okay, I'm going to start by saying, honestly, there's so much scope here. So there's lots of opportunities. But the way we think about it is what's needed is, first of all, we need a couple of things. We need better risk stratification. So we need better ways of predicting which women are likely to develop conditions that we know lead to stillbirth. Things like fetal growth restriction, preeclampsia, gestational diabetes. These are pregnancy-specific conditions originating from the placenta that we know we can predict, and we can reduce the risk once we know that those women are going to develop them. There are some treatments we can give. We need better ways of doing that. But that's only going to get us to about half of stillbirths. Half of stillbirths are either due to acute, so unpredictable causes, or unknown causes or rarer causes. For those, we need better monitoring at home, ways that you can pick up signals that there's a problem arising at home. That's really open to the digital, the wearables, the new sensor technologies are coming in there. How can we take signals that arise between scheduled antenatal care visits and use them to help make decisions about care, where, when, how. The third piece that's needed is, once we do recognise that a baby might be vulnerable, is we need to have proper diagnostics when you come into hospital. And then sadly, what we have now, look, we have ultrasounds, we have ways of looking at the baby's heartbeat, but these are really not great, if I'm honest, in terms, or they could be so much better, because they often overestimate, so you often get false positives, and they can miss cases as well. They tend to pick up late stage problems. So we need ways of better maternal fetal placental assessment, where we can really accurately identify the critical oxygen and nutrient deprivation, so we can safely say this woman requires emergency birth, this woman can continue her pregnancy. So those are sort of three areas where I see, and I'm going to just call out, another couple of factors within that. I strongly believe we fail in our maternity and antenatal care because access is so difficult. We've made it face-to-face in hospital with low sensitivity tests. So we just repeat it a lot. You can come into hospital 6, 8, 10 times for antenatal care. But that's not easy. It's not easy to scale. We know that we failed to scale those models of antenatal care in many, many countries around the world. Even in the US, we have maternity healthcare deserts now with no maternity care in county. It's a difficult model to scale because it's based on face-to-face, high resource, resource intensive and difficult to access. So what we need are technologies that can distribute this, can take it back to home, back to the hands of women, back to the community. That's going to be really important technologies. And the second piece is we need ways of analysing data, not in silos, not as point solutions, not as points in time, but bringing risk together so we can think of the dynamic changes across gestation, bringing together signals from mother, baby and placenta. I've worked in obstetrics for too long. We've had fetal medicine specialists or placental biologists or maternal medicine. It's crazy. There's three things going on and there's multiple feedback loops. We've got to be able to bring together the signals from all. And some of that complexity, is made for now, where we have such an explosion in bioinformatics, in data, in AI. There are real opportunities here to use that data.
What makes this area, especially for founders building in women's health and maternal health, challenging?
I think there's a huge perception about how difficult pregnancy is, and it's a misperception. Look, we have to be safe, and at no point am I saying that we shouldn't be safe. But I think there's this absolute fear that pregnancy is too hard. Somehow women are more vulnerable in pregnancy. There's conservatism, and that's across the board. From fellow doctors, particularly those that don't work in women's health. I sometimes speak to my cardiology friends and like, oh, you couldn't possibly involve a pregnant woman in a research study. Of course you can. Pregnant women want to be involved in research studies.
And tell me more about the program. How does Wellcome Leap think about supporting these breakthroughs companies beyond capital?
So one of the biggest things, I think, is the network. Wellcome Leap have created a sort of global health breakthrough network. There's more than 180 institutions now signed up to this network. What does that mean? It means that it changes barriers like contracting. So with the institutions under master agreements, it means that contracting can take. Well, our record for a contract with a team was actually, I think it was something like 122 minutes to go from change to getting the contract signed. In academia, contracts take forever. So we're reducing those sort of gaps because it means that we can say, okay, you've got an idea, we need to change this, we can contract now. So, reducing those kind of barriers is really important. As a program director, I found I was often advocating for researchers within their institution to say, you can do things faster. We can get this done. It doesn't need to be done always this way. And networking between as cross-discipline and startups, industry, academia, allowing that to happen much more effectively, coordinating that and helping with contracting, makes a huge difference. There's so much of research time and development time that is actually just doing the hard but actually technical bits in the background, not focusing on the research. So the administrative bits not actually focusing on the innovation. So I think that's one of the things that I think is so different about Wellcome Leap funding and how that's worked, and that what we do. We then go on and we try, afterwards there is this period where we think about transition funding, which is about how we're going from the innovation, the discovery, to getting it into the hands, I'm going to say of women and clinicians, but of people. That we do work in women's health a lot, but we also work across a number of different health conditions. So it's the translation of the discoveries to get them in the hands of the people that need them. And with that is funding, but also mentorship, connections, de-risking, the next investment, using the networks that are there to help de-risk the next investment. We want things to be successful and sustainable, but also allowing the right products to be built, not necessarily the one that's got the most commercial value in absolutely initially, but the one that's going to have the impact. And for us, that's thinking about where there's potential impact for access, to make sure that underserved populations, the products work, not just for those that can most afford them.
No, that's super impressive. I love that access. I think that's one thing I'm super passionate about as well, that health is right now overall built for only, I would say, rich and wealthy people. There's a massive gap about healthcare literacy, right, overall. So I think it's just so impressive that a program like yours not just focused on one region, like they're quite diverse and they're like really going after problems, and also having right data and research, I think could really transform a lot of things, because the data is missing piece in female health overall, right? And like across all categories. And we all know that it's just a massive gap.
Yeah, no, I totally agree with that. There's a data gap, but right from the outset, I think it's been important that we are involving people across different settings, because unless you do that from the outset and you're building for access from the outset, we're just going to get it wrong. So I think that's one of the tenets that's really strongly held, is we've got to keep that in mind.
No, absolutely. And how do founders get?
So Wellcome Leap run what we do most is we do fixed term funded programs. They're usually 3-year programs, funded to the tune of about $50 million US, and they are announced. The best way to do it is go to the Wellcome Leap website, sign up to the mailing list or LinkedIn, and you'll see the calls coming out. So we've got a commitment now of $250 million to women's health. There are we have In Utero was the first women's health program. We have programs in cardiovascular health in women, Alzheimer's in women, heavy menstrual bleeding, and there will be programs in development in autoimmune disease in women and mental health in women as well. So these are the sort of pipeline of programs coming up. That's the best way to be aware and to apply for funding from that. In terms of In Utero, as we move into sort of a phase where we're looking at more about the ecosystem, I think there may be other opportunities will be to think about what we need to be addressing this change from discovery to product to regulatory approval to access and reimbursement, and how we can do things in parallel. And I think there's real need here to think about, we've talked about this model where we've got technologies that are needed to look across fragmented care pathways, to look across gestation. Yet when we come to regulation and access and reimbursement, what we're looking at is sort of traditional siloed one intervention pathways. So we've got to think about how we're going to change that. We did it well in COVID times, actually. When we came together, we managed to change how we get from innovation into the hands of women and people, humans that needed them. But we need to think about how we can learn from that so we can fast track this. So it's not 22 years from discovery of a biomarker from preeclampsia to finding we still don't have that access now. What we need to be doing is saying, okay, how can we do these things in parallel so we're getting good, robust safety data, but data of clinical utility, data of cost effectiveness, and in a way that is designed around the users, women, and clinicians who need it. So there will be uptake, and those things are, we're going to need people who, decision makers, leaders in the ecosystem to help us with that aspect of it.
Great, amazing. And what does the success look like for Utero program over the next few years, and where do you think startups can contribute meaningfully?
I mean, I think really what we're doing now is we've got to a stage where we think we've got potential. When we model our technologies, there's potential for reduction in stillbirth. And what's important to say is that that's not if they're done individually, it's if we bring them together. And so that's the hard bit now, is us doing the translation, not of single technologies, but of multiple technologies in a package that works well, that can work in different settings. And that's what we're going to try and do. So we're looking at the opportunities for funding this, where we can work with partners and partner countries to do the necessary further development, research, and commercialization required for sustainable to create a sustainable ecosystem where we've got change maternity care, all around demonstrating that when we do this, so it's really talking about doing this to scale up in a setting where we can demonstrate a reduction of stillbirth by half. Our ambition is to have that scaled up across a nation, at least one nation, within 10 years. So that's where we're going next. There's a huge amount of work to do. We're at the early stage where we're catalyzing, the investment needed and planning for that. But what I would like, I don't think I'd be sitting with you in 10 years' time, but what I would love to be looking back in 10 years' time and saying, actually, this does work, we can do it, and we can get it into the hands of those that need it. Because there's 2 million babies a year that need this.
What's the one thing if you have to change today about women's health, and what that would be?
I think there's, I think there's been a critical change. The women's health is on the agenda, and that's amazing. Lots of people are talking about women's health, and there's a recognition of the problem, and that is amazing. But I really want to see that catalyzed into action. Tangible action is what I think is needed. And everyone can contribute to that, but it's actually not... And I think I can be guilty of this myself. There's been a lot of admiring the problem, right? You see a lot of talking about the problems, but we need to get on and start building the solutions. It's like we're waiting for something sometimes, I think, or somebody to say that's okay. Actually, we just need to start doing it.
Yeah, I totally agree on that. I think there's too much noise, but then we need to bring tangible actions and move the industry forward with some great innovations, and we can empower like the next generation, right? Absolutely. Great. Thank you so much, Sarah. It was really nice to have you.
Absolute pleasure. Thank you for having me, Navneet.